Pass. Okay, good evening, colleagues, our dear auxiliaries, friends, and guests. This is the 63rd Philippine Medical Association Medicine Week celebration with the theme Manggagamot, Mamamayan, Sama-samang Pagtugon sa Pandemya. This is our fourth lecture series. Fourth? Fourth, okay. The officers of the Olongapo City Medical Society, especially the chairman of the Medicine Week celebration, Dr. R.J. Manso, have lined up a series of very interesting lectures for us. A virtual applause, please, for Dr. Manso and the officers. We were overwhelmed by the number of attendees since day one of our lecture, be it the lay forum and the medical lectures and the future of the medical practice. The superbiotic lecture that we had by Dr. Ledesma last Monday evening not only will supplement but also complement our knowledge about COVID-19 in tonight's lecture on COVID in the gut and the gut, protecting the GI tract. Welcome and thank you, Dr. Arlan Mendoza Manso, for accepting our invitation, even on a short notice. Thank you, everyone, and let's have a good evening.
Thank you, Dr. Calapatia. Nagpasilip ka na naman.
Dapat meron ka din.
Let's give them the again, just to remind everybody that there is a pakulo lang for tomorrow. Si Antman ba sila? So kung dun sa mga wala, yes, last night, si Dr. Calapatia was Optimus Prime. Ako naman po si Bumblebee. Kanina, sino ba siya? Si Ant-Man? Tama, Doc? Ant-Man. Ayan po ako ngayon. So kanya-kanya na pong pakulo. So hopefully you could share the moment with us. Send your entries tonight. So we will have 3 judges, one from the MDs, auxiliary, and one from the med reps. Okay? So seryoso na po tayo. So for the webinar rules, again, we would like to request everybody to mute their microphones while the lecture is ongoing. If connectivity problems are encountered, disconnect and join again. Type questions and comments at the chat box at any time during the lecture, and they will be answered happily by the speaker. She should, during the open forum after the lecture. So I will turn you now to our moderator, who is a graduate of the University of Santo Tomas College of Rehabilitation Science, a graduate of the UST Faculty of Medicine and Surgery, bachelor in BS medical degree, and she had her internal medicine residency at Jose Reyes Memorial Hospital, recently graduated 2019. She belongs to a family of doctors. Ladies and gentlemen, Dr. Maricar Ridon.
Good evening. Good evening, everyone. Okay. As we all know, this pandemic has been living with us for the past 6 to 9 months. We are truly blessed to have this kinds of meeting for us to be able to learn more about the signs and symptoms, diagnoses, and treatment plans for our patients that contracted the said COVID-19 virus. However, we mostly focus on the respiratory symptoms and how to protect ourselves from the respiratory secretions. COVID-19 is like a predator waiting for us to be its prey, and you'll never know how and when it will attack. Day by day, new symptoms are added for us to watch out. So tonight, we will talk about another common and yet not so talked about topic on COVID-19, its effects and manifestations in the gastrointestinal tract. I am very pleased to introduce to you a very special colleague of ours that will discuss some of the most common GI complaints that may be a possible contributor in diagnosing as well as aiding us on how to treat our patients with coronavirus presenting with these symptoms. This just proves that medicine is really a continuous learning experience. So, Doc, without further ado, let me introduce to you our speaker. So our speaker took her internal medicine residency training at UST Hospital in the year 2008. She did her fellowship in gastroenterology at UST Hospital in the year 2010. And she is a fellow of the Philippine College of Physicians, as well as the Philippine Society of Gastroenterology and Philippine Society of Digestive Endoscopy. She completed her certifying course in COVID-19 Virology Pro at Mayo Clinic this July 2020. So, our speaker, Dr. Arl Ann Mendoza Manso.
Thank you, Rika, for the kind introduction. Good evening, everyone. So this coronavirus, this novel coronavirus disease has swept the entire world and has seriously threatened our way of life. Now, we can either cower in fear or face the enemy head on. And I know you all agree with me that fear is no longer an option. Knowing your enemy is the best way to assure a victorious end after any battle, which is why we do this. We continue to educate ourselves against this enemy to best equip us against a formidable foe. Before I begin, I would like to congratulate and thank the Olongapo City Medical Society for these COVID 19 informative venues, not only for the doctors, our families, as well as for all the members of the different sectors of the Olongapo City community. Let us be inspired and be advocates against outdated information. We are faced with this new illness, only discovered some 6 months ago, but as you have seen during these Medicine Week lectures, there is a continued evolution of data and evidences about it. So let us be challenged to always learn new information, share it, apply it in our clinical practice, and our everyday lives. Our objectives for tonight are to understand the fecal oral transmission of SARS-CoV-2 or SARS-CoV-2, to know about the different GI symptoms of COVID-19 and quickly try to comprehend its pathophysiology, to know of other gut concerns or other gastrointestinal concerns related to the COVID-19 pandemic, and quickly rush through management of these COVID-19 related GI problems. This topic, I understand, is actually very broad. There are very many aspects concerning the GI tract and COVID-19. So I don't want to overload you with too much information. I tried my best to make this lecture as concise as possible. Okay, so what do we know so far? COVID-19 is short for the novel coronavirus pneumonia, which is caused by the severe acute respiratory syndrome coronavirus 2, or the SARS-CoV-2 or the SARS-CoV-2. We know that it had emerged from Wuhan, Hubei province in early December 2019, quickly spread throughout China, then throughout the entire world, evolving into a pandemic. Okay, so we also know that the most common symptoms of COVID-19 are fever and respiratory symptoms. We also know that it's highly transmissible via respiratory secretions and contaminated fomites. We also know that there is a varied spectrum of infection ranging from asymptomatic carriers to severe presentations of the disease, actually resulting to some patients succumbing to the infection. And We also know that immune competence is a very important factor determining the severity of infection and symptomatology of infected patients. But what is it that we don't all know but should? So I've zeroed in on these four important concepts. We'll slowly and hopefully go through them one by one tonight. Okay. So gastrointestinal tract is a potential route of transmission. Okay, so as early as March 16 of this year, the Joint GI Society message of these four gastrointestinal and liver societies in the US, as early as then, they saw the possibility of GI secretions presenting with the SARS-CoV-2, and they were able to demonstrate the viral RNA in stool samples. Okay. This is an early study, one of the earlier studies by Wang, published in the JAMA in 2000, this year, of course, as early as March 11, which analyzed different samples for positivity of COVID-19, of SARS-CoV-2. Bear in mind that during this time, this is during the early stages, the early recognition of the virus, so there's no yet set guidelines on how to diagnose. Based on this study, they found that there are 32% of COVID-19 patients who have presence of the virus via RT-PCR in their pharyngeal swabs, and not too far at 29%, the virus was also detected in fecal samples. In this same study, electron microscopy was performed in 4 positive fecal specimens, which detected the live virus, even if the patients from whom the samples came from did not really have GI symptoms. This is a very good evidence showing to us that SARS-CoV-2 can be found in the GI tract. Okay, so if it is found in the GI tract, then naturally we can surmise that it can be spread through the fecal-oral route. The presence of the SARS-CoV-2 RNA in the stool was first documented by Holshue when the first confirmed case in the United States, a 35-year-old man with a recent travel to Wuhan, China, developed diarrhea on the 6th day of illness. Another study done by Cheung showed detection of the viral RNA in stool, and it was detected in both stool and respiratory secretions with a pooled prevalence of 48%. Furthermore, doing a subgroup analysis, they showed that those patients who had positive stool samples and negative respiratory specimens have higher prevalence at 70%. So greater than those who are both positive for the stool and the respiratory specimen. Another study by Zhang reported a high accuracy in detecting viral nucleic acids in stool samples. So what is the meaning of this? What does this mean for us? The presence of SARS-CoV-2 viral nucleic acids in stool has raised the suspicion that fecal excretion, environmental contamination, and fomites might contribute to viral transmission, especially since the virus has been found to be stable and viable up to 72 hours on these surfaces: plastic, stainless steel, copper, and cardboard. So these are the surfaces na make up our toilet bowl, yung ating mga bidet, no? So, nandun yung risk for transmission through these surfaces, okay? Okay, this is just to show you the summary of 4 early papers showing the prevalence of fecal RT-PCR positivity in COVID-19 patients. So prevalence ranges from 15 to as high as 55%. Now, the next question is, how much of SARS-CoV-2 are actually in the GI tract? In the saliva, SARS-CoV-2 has at least 3 separate routes to present in saliva. SARS-CoV-2 in the lower and upper respiratory tract, so from the lungs to the oral cavity via liquid droplets, from the blood to the mouth via our gingival crevicular fluid, and also there are some evidences showing that the salivary gland can be affected by SARS-CoV-2, either through a major or a minor infection. And this infection in the salivary gland ensues the release of particles into the saliva through our salivary ducts. What is the importance of these droplets? So the size of droplets can determine how far and long they can fly along with the airflow. Huge droplets within a short distance or touching infected surfaces spread majority of transmissible respiratory infections. These huge droplets or ito pong mga droplets with a diameter of greater than 60 micrometers appear to settle rapidly from the air kasi mabigat, no? Making the transmission risk at highest for individuals in close vicinity to the source of the saliva droplet. Small droplets, on the other hand, those with a diameter of less than or equal to 60 micrometers, can cause short-range transmission. But mind you, it can reach a distance of up to 2 meters. So maybe this is the rationale behind or the basis behind how long we should be in safe distance from one another when we do the social distancing practices. In a desirable environment, small droplets are likely to fade away into droplet nuclei with a diameter of less than 10 micrometers. These then become capable of long-range aerosol transmission reaching up to 48 meters. Okay. Now, interestingly, when we speak, cough, sneeze, or even as we breathe, saliva droplets are produced and shaped as particles in a combination of moisture and droplet nuclei of microorganisms. So each cough can produce 3,000 saliva droplets per nuclei, which is approximately equivalent to the quantity generated during a 5-minute chat. For a sneeze, it can produce roughly 40,000 droplets of saliva, covering several meters in the air. The gastrointestinal tract acts as a potential source of viral shedding with a demonstrable viral load that is present in fecal material. In a little more than half of patients, viral RNA was detected in stool samples at day 2 to 5 of illness and may persist up to 16 days. Up to 84% of patients were shown to still have persistence of stool RNA positivity despite resolution of their respiratory symptoms. Oh, what do you think is the reason behind this? So the magic word is tropism. Tropism, simply put, means the innate ability of an organism to turn or move in response to a stimulus. We all know, we've been hearing left and right that SARS-CoV-2 preferentially infects cells in the respiratory tract. But a lot of evidences have shown that it can be discovered and has also direct affinity to other organs in the body, specifically the intestines. And we call this the intestinal tropism. The key player here is the ACE2, the angiotensin converting enzyme 2 receptor. So this is ito na, ang very crucial step. This is the receptor used by SARS-CoV-2 to enter into the target cell, into the human cell, the human host. And it can facilitate the virus to replicate within our body. Again, it is highly expressed in the lungs. Tingnan niyo po, bakit nga ba mas nakakatakot si SARS-CoV-2? Because our ACE2 receptors in our body has 10 to 20 times higher affinity for SARS-CoV-2 compared to SARS-CoV. Okay, we have evidences to show that SARS-CoV-2 also has affinity to the GI tract and the liver. Why is this so? Because there is high expression of ACE2 receptors expressed in the enterocytes in the ileum and the colon. Staining of biopsy specimen also showed positive areas mainly distributed in the cytoplasm of the gastric and intestinal epithelial cells. Viral nucleocapsid protein was also detected in the cytoplasm of the duodenum and the rectum, and it was also shown that the cells of the liver and the bile duct has presence of these ACE2 receptors. This is very technical, a very technical and a rather intimidating slide, but the bottom line here is, as you can see, ano ba ang trabaho ng ACE2 at saka nitong mga ibang enzymes to facilitate viral entry into our body. So if you can recall the lecture delivered by Dr. Bergantin, the first webinar on COVID, she mentioned that the peculiarity of viruses is that they need the host to survive. Unlike the bacteria, the other microorganisms, they can exist in a separate ecosystem within the human host. The virus, on the other hand, it integrates its genetic makeup into the host cell. Okay, so ang trabaho ni ACE2, siya yung doorman. Papapasukin niya ang SARS-CoV-2 sa ating katawan. Now, there is an interesting new enzyme in play, yung TMPRSS2. Ito naman yung elevator boy. Okay, so pag napapasok na ng doorman ni ACE2, yung SARS-CoV-2 sa loob ng katawan, si TMPRSS2 ang magsasara para tuluyang makapasok ang SARS-CoV-2 sa atin. And it will help integrate the viral RNA genome into our bodies, into our systems. Tapos, magsa-start na yung cascade ng replication. Okay, why again is this TMPRSS2 interesting? Because other than being found in lung cells, it is again found in GI tissue, in the esophagus, in the ileum, and in the colon. So it is quite unfortunate that it is our own bodies that make us susceptible to accept COVID or the SARS-CoV-2. Okay? Ayan. Pasensya na po at medyo pixelated ang slide. I just wanted to show you this. I couldn't find a clearer image. I just wanted to show you that these receptors are present not just in the lung, not just in the GI tract and the biliary tree, in the liver, but also in the other organs of the body. The brain, the heart, the eye, the renal system, even the reproductive system. Kaya ganun na lang po talaga ang effect sa atin, sa mga infected na pasyente ng COVID-19. It can really have an unpredictable and stormy course. Ayan. So si ACE2 at si TMPRSS2. Okay. Now let's go to COVID-19 GI symptomatology. There is a pooled prevalence of 17.6% of COVID-19 patients manifesting with all or any of the following GI manifestations. So the top three are anorexia, diarrhea, and nausea and vomiting. Let's go through them one by one. So anorexia, based on majority of published articles on COVID-19, this appeared to be the most common gastrointestinal symptom in as high as 79% of patients. The mechanism of anorexia remains unclear. However, it may be partially explained by the existence of gustatory dysfunction in COVID-19 patients. In a study done in Europe, 88% of patients with mild to moderate infection had evidence of gustatory dysfunction. So gustatory dysfunction meaning changes or loss of taste, changes in taste, loss of taste, so ajusia or dysjusia, that's what we call them. And it is associated also, anorexia was also associated with olfactory dysfunction or anosmia, which is prevalent in almost 86% of COVID-19 patients. And this dysfunction may exacerbate loss of appetite. So what about diarrhea? Diarrhea represents the most relevant clinical aspect of gastrointestinal involvement in COVID-19. Prevalent in up to 33-34% of COVID-19 patients, but still with no clear-cut pattern of evolution. It may precede respiratory symptoms 1 to 2 days prior. The onset may be after the respiratory symptoms have set in, but the common denominator in all evidences is that if it will appear, onset is usually on the first 8 days, 1 to 8 days of infection. The SARS-CoV-2 directly affects the digestive system, and this causes extensive tissue damage. Indirectly, it can also have an inflammatory reaction. It can incite an inflammatory reaction resulting in changes in the intestinal flora, and this is what we call intestinal dysbiosis. So this viral effect will explain the symptoms of diarrhea in patients with COVID-19. Okay. Sandali lang po. Nagkakaroon ng technical difficulty kasi yung host dito rin sa laptop ko gumagalaw. Okay. So going back, Sorry for that interruption. Relating to the lecture delivered to us by Dr. Ledesma last Monday on probiotics, he mentioned a little something about dysbiosis and leakiness. SARS-CoV-2 not only incites inflammation, disrupts gut microbiota, it also renders our intestines with increased permeability. And this is what is termed as gut leakiness. So these are the possible hypotheses why COVID-19 patients may present with diarrhea. Interesting to note also, if I may add, the increased incidence of diarrhea has been noted in patients with severe COVID-19, and this can be explained by a phenomenon called the cytokine storm, which we will discuss later. So the third most common gastrointestinal symptom of COVID-19 is nausea and vomiting. Okay? So symptoms of anosmia and ageusia, that is loss of smell and loss of taste, as I mentioned earlier, were commonly associated with nausea, the prevalence of up to 26%. This may or may not accompany other GI symptoms. And I mentioned already na preempt ko na yung cytokine storm. No? Kasi if we see nausea or vomiting in COVID-19 patients, this can be the initial manifestation of what we call the cytokine storm. What is the cytokine storm? So, cytokine storm is when various inflammatory cytokines are produced at a much higher rate than what is normal in the response of the body to infection. So, this overproduction of cytokines creates or causes a positive feedback on other immune cells to occur, which allows for more immune cells to be recruited to the site of injury, resulting to organ damage. So this excess in cytokines, it makes the blood vessels more permeable, thereby causing yan, yung ARDS, yung SIRS, and eventually multi-organ failure. Nausea and vomiting can be the initial symptoms of cytokine storm in COVID-19 patients, and the manifestation of severe diarrhea can also be related to cytokine storm. This is a very deadly feature that's very pertinent to COVID-19 or SARS-CoV-2. Okay, so this just illustrates to us how unpredictable the GI symptomatology of COVID-19 is. Its timing of onset, its duration may vary from patient to patient. But one thing that is commonly found in publications and in all evidences is that rarely do COVID-19 patients present with only GI symptoms. So it's either a prelude or a prodrome prior to respiratory symptoms, or it ensues once the respiratory symptoms have set in. So if the patient presents merely with just GI symptoms, we don't think that this could be COVID-19. So the presence of gastrointestinal symptoms also have differing evidences in terms of correlation to the disease severity. Almost equal in number are those studies associating presence of GI symptoms with more severe disease and worse outcome, as are those studies that found no association between GI symptoms and disease severity. So baka in a couple of months, there will be new evidences again. We are still constantly learning about the novel coronavirus. Interesting to notice this study done in the United Kingdom, which gives us a very good data on how children may manifest with COVID-19. So this was done on 992 children of healthcare workers. So from those who had COVID-19, half of them presented as asymptomatic cases. For those who had symptoms, majority had fever. And the next most common presenting symptom are GI symptoms. According to the paper, diarrhea and vomiting may be presenting symptoms of COVID-19 in children. And just like in adults, anorexia appears to be a pertinent symptom. Supporting this, the presence of gastrointestinal evidence of COVID-19 in children is this study, the study that I kept on mentioning since the beginning of this lecture. They found that pediatric patients who were positive for COVID-19 were actually nasopharyngeal swab negative. But they found that the rectal swabs of these patients were positive. This evidence also shows us that viral shedding in the GI tract may be longer than the respiratory tract, suggesting the possibility of longer infectivity via GI secretions. What about the liver? Liver injury may occur during the course of the disease, again attributed to the abundance of ACE2 receptors in the endothelial cells of the liver. And the liver injury in COVID-19 is multifactorial. It can be direct, resulting from a cytokine storm, or it could be indirect, an indirect result of hypoxia from pneumonia, an indirect result, collateral damage to the liver as a result of pneumonia-associated hypoxia. The clinical picture of liver involvement in COVID-19 are shown in as elevated transaminases, abnormal liver function test, elevated bilirubins, low albumin. Okay, studies have also shown that a pre-existing liver disease in a patient, viral hepatitis, alcoholic hepatitis, may be a risk factor. So acute pancreatitis, acute cholangitis, or acute cholecystitis may also be presenting symptoms of COVID-19 or may present as complications of the disease. Okay. So going now to our next objective, what may be other gut concerns in this time of the pandemic? Now, these are common gastrointestinal symptoms not directly related to the virus itself or COVID-19 itself, its pathophysiology, but those that we ourselves and our patients experience because of maybe our stress and our anxiety, our inability to accept the new normal. I'm talking about functional diseases of the GI tract. The most common we encounter is stress gastritis. So this is triggered by anxiety, by our troubles, no, by our thinking too much about what is happening around us. And the question that comes in mind is this similar? Is it the same as stress? Oh, before that, sorry, uh, stress gastritis or functional dyspepsia can have a myriad of symptoms. It could range from simply bloating, early satiety, nausea, vomiting. So matatakot tayo, baka COVID-19 na ito. Anorexia, another pertinent GI symptom of COVID-19. And typically, of course, the ulcer symptoms, the ulcer-like symptoms, the epigastric pain syndrome of upper abdominal pain and stomach pain. So I was talking about stress ulcers. So are stress gastritis and stress ulcers the same? Magkaiba po ito. The main difference is the pathophysiology. Stress gastritis, there's nothing organically wrong with the patient. Stress ulcers are instigated or as a result of physiologic stress. And physiologic stress can come as a form of the following. So gastritis, ulcers, stress gastritis, worry yan, stress tayo, anxiety. And for stress ulcers, ayan, surely you are familiar with the Curling's ulcer or those we see in our burn patients, in our septic patients, our shocky patients, those patients who had trauma. The Cushing's ulcer, which we see in patients with increased intracranial pressure. And the common, the most important difference between the two is that stress ulcers do not present with typical digestive symptoms. Hemorrhage is the usual presenting manifestation. And because there's a physiologic stress, the common denominator of all these physiologic stresses causing stress ulcers is ischemia. So there is a disruption in the blood supply of the gut leading to ulcerations. Endoscopically, we will also be able to differentiate between stress gastritis and stress ulcers because stress ulcers have a predilection to occur in the fundus or in the gastric body, whereas stress gastritis or functional gastritis, functional dyspepsia would present in the antrum or in the prepyloric region. The extent of injury will also differ. Usually for stress gastritis, mas mild injury lang yan. Mga gasgas lamang, minor erosions. Whereas in stress ulcers, ranging from minor erosions to really big bleeding ulcers. Okay. What about IBS? Ang typical nating nararamdaman if we have this is dati okay naman ng BM, biglang nag-constipate or ngayon biglang madalas nang dumumi. It's typically an enhanced gastrocolic reflex. So every time we eat, we feel like going to the toilet. We notice a little mucus in the stool. And of course, the factor of emotional and anxiety as a trigger of these symptoms of irritable bowel syndrome. So cramps, bloatedness may occur, but the pertinent symptom here is the changes in stool consistency and frequency. We used to use the Rome 4 criteria to diagnose patients with irritable bowel syndrome, but as you can see, there's a very crucial time element. Nowadays, it's just a little over 6 months that the COVID-19 pandemic has happened, so the patients might not fit into the time criteria. Still, we can label as IBS. If you can see here, the warning signs. So, wag din naman po tayong mag-underdiagnose. So, always exercise sound clinical judgment before we label IBS. We make sure that the warning signs are not present in the patient. Okay, what about drug-induced gastropathy? We are so afraid to feel any form of muscle pain, any flu-like illness, any headache, because we feel that this might be a sign of COVID-19. So we are so eager to jump the gun and take pain relievers here and there. Okay, these NSAIDs, as of course you all know, can cause significant peptic injury. So similarly to the stress ulcers, they will not present as your typical ulcer-like symptoms. They usually present as occult or overt upper GI bleeding. And not all patients naman po will be at risk for drug-induced gastropathy. So just make sure to take your pain relievers on a full stomach and make sure that you don't have the risk factors to have drug-induced gastropathy. You're not elderly, don't smoke, you don't have presence of comorbid conditions, no history of peptic ulcer, and you don't have a daily use of antiplatelets in your treatment regimen. Again, injury may range from mild erosions to high-grade ulcer disease. What about drug-induced liver injury? The drugs we take, which we think might help us avoid COVID-19, may actually cause us more harm than good. Drug-induced liver injury is on the rise during this pandemic, as left and right we read about the novel drugs against it, things that can protect us. So in addition to antipyretics and analgesics, we see wrongful use or too much extended use of antibiotics, some antivirals which were initially used for COVID-19 patients like lopinavir and ritonavir were found to cause liver function disturbances. Okay. Glucocorticoids, Chinese medications, different forms of herbal concoctions may all cause significant liver injury. Again, we are not doing any good taking all these unnecessary preparations that we think may help us or our patients. Unwittingly, we put them instead in harm's way. So we have to be able to make sure that those drugs that we take don't have any hepatotoxic elements or contents in them. Okay, so we're now to our last objective, treating functional GI disorders. So as I said, ang dami po na yon, sakit ng tiyan, no? Lahat natatakot, lahat tayo nag-a-adjust sa new normal. We see it in our clinics, our families and friends, even ourselves. We were and maybe some of us are still very scared and paranoid to get infected with COVID-19, which is why we overthink what we feel. I myself conduct a mini checklist in my head before going to bed, and I also do it upon waking up to make sure I do not have the COVID-19 symptoms. Okay, it is true that what we feel and what we think we show. So there is a good majority of GI symptoms felt nowadays that are stress and anxiety related. Knowing this, I guess the take-home message is let us be more discerning. Huwag po tayo masyadong matakot at huwag din tayong malakot. Laging sound clinical judgment. Hindi pwedeng puro COVID-19 ang nasa isip natin that we forget other illnesses. I think the other thing that the COVID pandemic has emphasized or instilled on us is we keep on underscoring mental health as Filipinos. So it's still taboo na mga sakit sa isip, mga functional illnesses dahil nasa stress lamang at na detention lamang ang isip. It's actually true. Mental health is very crucial nowadays and they manifest in the gut. Meron talagang enteral nervous system na nagdidikta ng ating nararamdaman, nagmamanifest sa ating tiyan, sa ating bituka, no? Sa ating sikmura. Okay? So, absolutely necessary only, we give medical management. Diet modification, we not really automatically take anxiolytics, but anything that can relieve our stress, we encourage our patients to do so rather than take drugs left and right. But for stress ulcers and NSAID-induced ulcers, proton pump inhibitors are still the drug of choice. I remember, for those of you who have attended Dr. Ledesma's lecture, there are some safety concerns raised against PPIs rather, proton pump inhibitors. Okay, COVID na rin yung isip masyado. Okay. Yes, there are indeed evidences to support that. Even before the COVID-19 pandemic, in fact, several studies have already showed that long-term proton pump inhibitor therapy in certain subset of patients can increase the chances of hospital and community-acquired pneumonia. So this is one of the good studies. They found that it is higher in older patients, in the elderly, and in diabetic patients who have been who have been in prolonged hospitalization. Okay. The PPIs, why is it related to pneumonia? Just to give you an overview, one of the main functions of gastric juice is to inactivate swallowed microorganisms, which inhibit infectious agents from reaching the intestine. So this makes it the first line of defense against pathogens. PPIs, as we know, effectively suppress gastric acid production, and this will result in increased gastric microbiota and up to small intestinal bacterial overgrowth. Now, this overgrowth of bacteria in our stomach and in our intestines have a tendency to microaspirate them, and it leads to bacterial colonization of the lung. In COVID-19 patients, in addition to already this known evidence prior to the COVID-19 pandemic, there has been a postulated indirect effect on ARDS development, triggering secondary infection in patients with SARS-CoV-2. It has something to do with the PPI's ability to modulate immune responses by inhibiting neutrophil function, as well as PPI's ability to inhibit significant anti-inflammatory activities of our cytokines. Additional evidence showing to us the importance. No, it's not really that proton pump inhibitors are the enemy, but judicious use. Discontinue when not needed, and weigh benefits versus risk, and give at lowest effective dose for the shortest recommended duration. Let me remind everyone that these are studies done in patients on different levels of COVID-19. The researchers themselves claim that there are some confounders, some limitations to their studies. Careful discernment of evidences po tayo. A case-to-case approach for each patient. But what is important is judicious use, not just of the proton pump inhibitors, but medicines in general. So intelligent prescription, isa kasi ang proton pump inhibitor sa mga gamot na madali nating ireseta. Konting sumakit ang tiyan, konting kinabag, ito na tayo, proton pump inhibitor. Okay, so baka may iba namang kailangan, baka hindi naman kailangan. So rather than maybe thinking of increasing the dose of your proton pump inhibitor, consider adjuncts, advise the patient. So intelligent prescription, consider benefit versus risk, consider patient profiles. This is, for example, an elderly patient with a history of bleeding. Do we continue bleeding with aspirin, but she needs her aspirin because she had a stroke in the past and she's diabetic? Do we stop the proton pump inhibitors? Versus another case wherein the lola who is diabetic just has occasional epigastric pain every now and then. Kailangan niya ba ng proton pump inhibitors? So we have to look at each patient individually and tailor make the management as the patient comes. So emphasis on lowest, most effective dose at shortest, most effective duration. For drug-induced liver injury, when in doubt, don't take it. Learn to read labels, no active components, understand and research these substances, these supplements, and anything we intake or prescribe. We should all be very wary of substances that can injure our liver. So you will be surprised. There's actually a long list of hepatotoxic components in our textbook. Okay, so you think it's safe, but it's probably not. It could be safe for one patient, but not for you, because there are idiosyncratic liver reactions or drug reactions to the liver. Okay, but should it happen, discontinue the offending drug. If you're lucky, the liver naman is very resilient, just give it a little rest, give adjuncts if need be, eventually it will be resolved. But also don't take drug-induced liver injury with a grain of salt. It can be dangerous, it can be fatal. So, hindi po biro ang pag-alaga sa ating mga atay. Okay? So, konting singit lamang po, just for those of you who are curious, is there a need for endoscopy? Can we do endoscopy at this time of the COVID-19 pandemic? So the Philippine Society of Digestive Endoscopy Working Committee gave us this guideline to prioritize and to do emergent urgent indications for endoscopy. So elective cases, as much as possible, knowing the possibility of transmission via the fecal oral route, keep ourselves protected, our staff protected. So hindi na muna ideal to perform elective endoscopic procedures at this time. Okay, so to end, my take-home messages are, let us not underestimate the enemy. The GI tract transmission of COVID-19 is real. It is present in our saliva, our intestinal secretions, our feces. It can also affect our liver and our biliary tree. Not to mention, it affects our mental health, manifesting as different functional gastrointestinal symptoms as well. Let us not be hasty in taking and prescribing meds. The key is judicious use, intelligent prescriptions. Be mindful of those that we intake. The GI tract and the liver can be injured by drugs and other supplements if we are not careful. So how do we defend our gut against against SARS-CoV-2 to prevent ourselves from getting COVID-19? Proper nutrition. So eat well, eat right. Vitamins and minerals, hindi necessary na supra-therapeutic dose tayo. So just the usual recommended daily allowances, we take them. Probiotic supplements have very good evidence as it will mitigate intestinal dysbiosis and will also help restore leaky guts and help protect us against the good bacteria, can help defend our gut against SARS-CoV-2. And the 5 Fs, so these are the protection against COVID-19 transmission through the gut or SARS-CoV-2 transmission through the gut. Our fingers, so hand washing po as emphasized by the COVID and the Planet and ako o laban sa COVID lecture. So flies, keep our surroundings sanitary. Fields, regular mechanical disruption of possible contaminated surfaces to prevent contaminated fomites. Fluids, wear our facial protective equipment, bear in mind the drawing, the picture on droplet size. Okay? Kaya malaki, kaya maliit, kaya pinakamaliit, pwedeng magkalat. So our facial protective equipment, very important. And the last F is food. Fecal oral route, so don't share utensils, let's not eat as a group, let's not congregate, wag na muna tayo mag-party. Okay, and make sure to always sanitize our toilets, our bidets. Okay, so my fellow healthcare workers and our families, we can all be heroes if we want to be. Let us be brave against wrong, outdated information and practices. Huwag po tayong matakot magsalita kung meron tayong alam. Madami tayong natutunan. Let us incite change if it is needed. Bukas ng gabi, matututo pa tayo sa dalawang magaling na experts. So, let us continue to fight against COVID-19 as one. Together, sama-sama po tayo against one common enemy. So, I leave you this quote from Optimus Prime. Maraming salamat po sa inyong pakikinig.
Congratulations, Dr. and thank you for that very informative lecture. Now, let us proceed. The floor is open for any questions or clarifications. You can type your questions at the chat box or you can unmute your gadgets po so that we could hear your questions. Any questions po from our participants? No questions? Dr. ako po may question.
Sige.
Sige po. Actually, hindi to sa akin galing eh. Since there were studies stating that PPI can increase the risk po of COVID-19 infection, are there any alternative medications we can give our patients for acid-related disorders such as GERD or dyspepsia?
Okay, there are actually a lot of treatment armamentariums available. In our setting in Asia, we're fortunate to have prokinetics. So for patients presenting with dyspeptic symptoms, yung kabag, kasi sa US walang prokinetics. So we underestimate the importance of these prokinetics. We can use them. Antacids can also be used as adjuncts na bibigyan lang agad ng nauunahan lang ng pasyente na hindi effective because they expect it to be a long duration of effect. So we have to emphasize it's short, fast acting, but the duration is short. So yan yung mga possible nating gamitin. Probiotics are they actually have very promising evidence against dyspeptic symptoms as well. So if it's really not that severe of an epigastric pain or of a GI symptom, we try to use the adjuncts first before we go to proton pump inhibitors. Lalo na pag high risk yung pasyente, yan, elderly, diabetic, medyo mag-shy away muna tayo sa mga PPIs.
Thank you po, Dr. Another question from Doc Armin Mendoza. He said, congratulations to the speaker. Wonderful lecture. Is the SARS-CoV-2 characteristic of ACE2 and TMPSS involvement specific only to CoV-2 or the other SARS viruses as well?
There is also affinity. The SARS-CoV viruses, they have an affinity to the ACE2 inhibitor and the TMPSS. But what is peculiar with SARS-CoV-2 is the 10 to 20 times affinity. So mas madikit sila kay SARS-CoV-2. Kaya siguro mas virulent ang course compared to the other SARS, the MERS-CoV and the SARS-CoV. But they also have receptor affinity to ACE2 and TMPSS.
Okay. So from Dr. Briones, do you recommend probiotics to COVID patients with diarrhea? And for how long would you give it?
Okay. As I mentioned earlier, probiotics can mitigate intestinal dysbiosis and restore gut microbiota. So pwede siya. It's actually a recommendation to give probiotics in patients with COVID-19 presenting as diarrhea or presenting with diarrhea. And also consider the use of the non-absorbable antibiotics like rifaximin as treatment. Depende sa severity. And then yung treatment duration is case-to-case basis. If the patient needs it for a longer time, probiotics naman, we can give it at a longer period of time. But of course, for antibiotics, non-absorbable antibiotics or yung mga anti-motility like loperamide, as much as possible, we just use it when the symptom is present and we discontinue once it's already gone, once it's resolved.
So from Dr. De La Cruz, thank you for the nice presentation. I think, is there any possibility that the stool may test positive even if respiratory sample is negative?
Good evening po, Doctor. Thank you for the questions. I forgot to acknowledge the questions earlier. Sa atin po kasing setting, as far as I know, we don't check stool specimens we don't subject it to RT-PCR in our setting. Pero base nga po sa mga data from China and the US and Europe, nakita nila na kahit negative ang respiratory specimen, may nagpa-positive sa stool. So, pwede siguro, maybe magkaroon tayo ng chance for a local study. So, we have the local experience. Kung ganun din sa mga Filipinos na magpa-positive sa respiratory kahit na magpa-positive sa stool kahit negative sa respiratory. Because the journal that I quoted earlier, despite negative respiratory specimen, sa stool nagpa-positive. So, for pediatric patients, nakita nila ganun din. We would have to explore maybe on that, inspire the younger colleagues like Rika to make studies.
Binasa, Doc. Thank you daw po, Dr. from Dr. De La Cruz.
Okay po.
So, Doc, another question. Is there any case who presented with GI symptoms alone, Doc, without any lung involvement?
Okay, the evidences show rarely. Kung GI symptoms lang na walang respiratory symptom, kasi talagang ang affinity ng SARS-CoV-2 pulmonary eh. Pwedeng may fever, pero kasi, di ba we were told by the past lecturers, the respiratory and the fever, they don't need to all appear. Pero siguro kung may lagnat, nagdududa pa rin tayo. But if it's just respiratory, GI symptoms like isolated diarrhea, isolated nausea and vomiting, or anorexia without fever, and based on the evidence that we have at hand, it's rarely a presenting symptom of COVID-19. So nandun lagi si fever and or respiratory symptoms. So GI symptoms alone, rare siya.
From Dr. Art Mendoza, to prevent continuous shedding of virus, would you advise use of anti-diarrheal combined with probiotic? Superb lecture daw po, Doktora.
Kailangan niya pong sabihin yun kasi that's a very interesting question. Yes, we do give antidiarrheals in COVID-19 patients who have diarrhea. This will be an effective way to prevent fecal virus shedding to protect the healthcare workers from being exposed. So yes, we can use antidiarrheals combined with probiotics. It's actually one of the treatment armamentariums for COVID-19 patients with diarrhea. We give loperamide with probiotics and or the non-absorbable antibiotics if needed.
So, any more questions po? Ang haba ni kay Doc Baluyot. Good evening po, Doc. This question po is related to a GI complication, upper GI bleeding that we encounter on SARS-CoV-2 confirmed patients admitted who started on IV steroids and anticoagulant as part of the management. Since some of these drugs are given as primary prophylaxis for complication of COVID-19, and in several studies, use of these drugs has really decreased the mortality and has shortened the duration of COVID-19 illness, do you recommend complete discontinuation of steroids or anticoagulants even if the bleeding has completely resolved po? Or we can assume po if potential benefit outweighs the risk of rebleeding. Patient has low risk factors.
Okay, I'm not sure where your reference is, but new evidence have shown that glucocorticoids and anticoagulants are no longer used to decrease mortality in COVID-19 because they found that glucocorticoids not only would cause stress-induced mucosal injury in these patients, this can also be a risk factor for liver injury. So anticoagulants, kung may bleeding, of course, we discontinue, but there is also it's a double-edged sword. Again, patient to patient, benefit and risk. Treatment of COVID-19 is in constant evolution, but if the treatment, the controversial treatment can cause the patient more harm than good, better to discontinue. Just err on the safe side. Don't give it. If the patient bled, kahit na tumigil pa ang bleeding, don't give it. Kasi ano pa rin naman eh. We still, as much as possible, we want to give medicines or treatment that will not cause patient more harm. As it is, may COVID-19 na. And these are all still experimental. These are all still undergoing trials. Wala pa talagang hard and fast rule eh. So siguro, to be safe, kapag may side effect, pag hindi naging okay sa pasyente, stop. Tapos, walang sense na ibalik pag okay na siya. Kasi the fact na nagkaroon ng una, pwedeng maulit. So that's my 2 cents about it. If it makes the patient have harmful effects or if it does the patient harm, then discontinue.
Doc, follow up po dun sa other alternative drugs sa PPI. Can we use rebamipide instead po?
Yes, actually, lalo na kapag may NSAID-induced gastropathy, rebamipide actually has very good evidence on facilitating healing of NSAID-induced gastropathy. Ang Ang downside lang ni Ribamipide is it's a 3 times a day dose, so it might be a little costly for the patient. Actually, you give it as an adjunct for NSAID-induced gastropathy or bleeding. Mas mapapabilis ang healing. Ribamipide is actually a good drug of choice. But for functional dyspepsia, kung wala namang organic na problema,
Any more questions po from the participants? From Dr. Briones, is there benefit to giving high dose of zinc to patients with diarrhea on top of anti-diarrheals and antibiotics?
okay, zinc is a very powerful gut support. Not just for pediatric patients, but for adults as well. But the Aspen, ang guidelines kasi wala pong nakikitang evidence ang supra-therapeutic dose. So kahit siguro mag-overdose tayo, baka hindi rin tayo matulungan. So we just stick to the recommended dose, and that should be enough to help resolve the symptoms or protect the gut. Hindi na natin kailangan mag-high dose pa.
Any more questions po from the participants? Ayan.
Wait lang, Rita. So, si Dr. Calapatilla privately messaged me, wouldn't the anti-diarrhea meds prolong COVID-19 in the GI tract? Napapaisip po ako dito sa tanong ninyo. Okay, so the main mechanism of action of anti-diarrheal drugs are to stop or to render the intestine hypomotil. Kasi nga po, pag nagtatai tayo, hypermotility ang usual na cause ng pagtatai. Probably not, because as we learned from the other lectures, COVID-19 just has a specific time duration in the body. So whether or not we take these anti-diarrheals, matatapos po yung infection eh. So for me, I don't think anti-diarrheals would prolong COVID-19 effect on the gut. So, I think.
From the question from Doc Art, what is the long-term effect of the COVID-induced liver and pancreatic injury?
Okay, these are actually just case reports that I've encountered in my research. The acute pancreatitis as a manifestation. There's one who had acute cholangitis and acute cholecystitis. Hindi po natin ini-expect na magkaroon ng long-term effect because this is just a consequence to an active acute infection. It is unlike, for example, acute pancreatitis secondary to alcohol drinking na pwedeng predispose sa pasyente ng mga complications like chronic pancreatitis or pseudocyst formation. So of course, the first prayer is na ma-survive nung pasyente yung GI complication, but I don't think it would have. But still, it is quite too early to find out long-term. Siguro maganda po na magkaroon tayo ng series of follow-up dito sa mga pasyenteng ito sa case report. So sana mabalitaan nila tayo kung nagkaroon ng long-term effect. Kasi 6 months pa lang yung COVID para malaman natin kung nagkaroon talaga o hindi.
Thank you po for answering, Dr. Any more questions po? Wala na po. Doc RJ, mukhang...
Parang wala na.
Opo, mukhang okay na po, Doc.
Alin?
Congratulations po, Doktora.
Thank you, Rika. Thank you po sa inyo lahat.
Conjugal kasi yung laptop eh. Teka lang. Okay. So, wala na pong questions. Ako, wala akong questions. Do not question the wife. Asa na? Okay. So, awardan na lang natin siya ng Certificate of Appreciation. We award the Certificate of Appreciation to Dr. Arl Ann Mendoza Manzo in grateful appreciation as guest speaker for the topic COVID and the Gut. As part of Medicine Week celebration, this 23rd of September 2020, signed by Dr. Paulo Villarreal, Secretary of OCMS, myself as a Chairman of Medicine Week, and Dr. David Calapatia, President of OCMS. Likewise, to Dr. Maricar Redon, in grateful appreciation for moderating COVID in Lagat as part of the Medicine Week celebration, signed by Dr. Villarreal, myself, and Dr. Calapatia. Thank you. So for my closing remarks, I won't say anything because it's always the wife who has the last say. So I would just like to invite everybody for tomorrow's PAM night. It will be our first virtual PAM night, hopefully the last. Please share your time with us. We have 2 lectures for tomorrow. We have big time lecturers, Dr. Mario Panaligan, an infectious disease specialist and the president of the Philippine College of Physicians. He will be giving a lecture on COVID updates. So actually, he's still doing his lectures because he is currently in the European Society of Infectious Disease conferences now, getting updated as well. And our second lecturer will be Dr. Edsel Maurice Salvania. I know you know him sa lahat ng Viber, Messenger, and Facebook posts. So he will be talking on COVID and the healthcare worker. So see you all tomorrow. Reminders dun sa mga costume pictures. Please send them to ocmsofficial@gmail.com. We will be having performances from the medreps, the auxiliaries, and selected MDs. And contest, meron tayong raffle. Again, Dr. Villarreal and Dr. Roldan had a randomly selected winners for tonight's activity. So again, extremely espresso gift certificates. So first winner is Dr. Julius Cesar Farin, 500 peso gift certificate. Second winner and second time winner kasi nanalo na rin kahapon, Dr. Tony De La Cruz. Okay, swerte. And our last winner who will win 1,000 peso gift certificate from Extremely is Dr. Rene Balmaceda. Winners can privately message Dr. Villarreal or Dr. Roldan for where they will pick up the gift certificates. And a gentle reminder to all members who have unpaid dues, you may coordinate with Dr. Roldan. Deadline for the annual dues is on September 30. So with that, thank you very much and good night, everybody.
Picture.
Please open your videos.
Sa kanya, kamusta naman?
Ito yung kay Dr. Leia eh.
Ganun ba? So sabi niya po sa akin, hindi ko raw po alam ang mga importanteng bagay. Sinasabi.
All right.
Okie dokie. Thank you so much.
Good night po.
Good night. See you tomorrow.
Thank you.